So I just need, there we go. So let's just, you guys jump in whenever you want to. I just tried to make a list of some of the, try to outline what the patient might be indicated for a SCR. Painful shoulder after failed PT, secondary irreparable rotator cuff tear. Probably all agree on that. Superinfraspinatus maybe often is retracted beyond the glenoid edge, to or beyond the glenoid edge. A grade 3 or greater muscle atrophy, suggesting that it may not be repairable, may not heal. Again, looking on that sagittal view in the MRI. Pseudoparesis, this is where it gets controversial. You know, if they're actually paralytic and they can't move their arm, almost like a deltoid problem, that patient's not going to get better. But somebody that's very weak, when they try to get to 90 degrees, or let's say above 90 degrees, is perhaps one of the better definitions. But how do you guys define pseudoparesis?
Well, I think that on my patient that I presented to you, you know, if you use the 90-degree rule, he would have been pseudoparetic, but I don't think that's a good way to do it. I think, to me, pseudoparesis, I really look for anterior superior escape as a key element of the pseudoparesis.
Okay. And they should have good passive range of motion, because oftentimes you're trying to rule out a glenohumeral arthritis that is going to continue to be painful even if you repair the rotator cuff, or an intact or repairable subscapularis. I think the studies have shown that an intact subscapularis is better, or at least a repairable subscapularis is a better outcome, and also intact deltoid, of course. So factors for discussion: radiographic evidence of cuff arthropathy, which, as we know by definition, is a glenohumeral arthropathy from rotator cuff insufficiency, which leads to an acromiohumeral arthropathy. Will you all allow for a little spur at the bottom of the humeral head, or are you hard liners on this, or what's your feeling?
Go ahead, Mike.
I think it just depends on how, a little spur doesn't worry me too much. It would depend on how advanced that is. But if it's a younger person and, you know, this is their last shot, then I think a little bit of glenohumeral osteoarthritis is not a game changer for me.
Good. Yep. I would agree, but I just want to see that when I move them passively, that doesn't, the pain with passive motion is not equal or greater than, to them, for them to know they probably have that discomfort with external rotation or with an abduction. So acromiohumeral distance, what's your cutoffs for that? I mean, some papers say even if it's less than 4 millimeters, but you can increase it with a sulcus sign maneuver, that you're probably okay. Or if it's obviously if it's 6, 7, 8 millimeters, you're probably in good shape. What do y'all have cutoffs for this?
I don't think I have a cutoff, but I think it's more likely to fail when you get even below 6, or for sure below 4. You know, I mean, I think that graft can just get shredded. I think the graft has a hard time holding the head down in the long run.
All right. So there's one study in 2021 arthroscopy. It looked at the prognostic factors for a poorer outcome, and they found the only statistically significant were female gender or a torn subscapularis that was not repairable. But there was a trend towards a worse outcome with high BMI or lower preoperative flexion. So with a female gender, I mean, my best patient was a 52-year-old woman who went back to playing tennis again. So I mean, is that just an age different, or if they have osteoporosis, or can you guys give me some tips about how do you sort that out?
Go ahead, Mike.
You're talking about age and BMI and patient-specific factors?
I'm talking about, well, initially I'm just talking about female. So do not do females because of this evidence at any age, or do you not care, or how do you do that? I just have I'm a little more, I'll do an older male because I figure their bone's going to be better. And the female, I'm a little more likely to go towards something else, or possibly a reverse. But how do you feel about the gender issue?
It's interesting. I haven't, thinking back, not about SCRs that I've done, there's not that many females I've done it on. What's your guys' percentage, would you say?
It's probably 50-50 with me, actually.
How have your
just
results
anecdotally
with females?
Well, I can think of some of the older ones that failed, and then even some in their young 60s that failed. But as I said, my first and best patient was 52-year-old woman, so I don't rule it out. But if I know that they've had trouble with anchor fixation from a rotator cuff repair, and because the bone is soft, and then there's a higher chance, I think, that the humeral bone and or glenoid bone may not have as good a fixation. I go at that with caution. Jim?
I agree with you. I have very few, if any. I'm not sure if I remember doing it on a woman. I don't know why that is. But I think I would be careful about poor bone quality and trying to, think about how you're going to get this graft to heal, right?
Right. All right, so going on, we talked a little bit about pseudoparalytic. One of the controversies, 2 or 3 medial anchors. Personally, I've just been thinking about this, and if I can do it with 2 anchors, I like that. I think the operation's easier, shorter duration. I've been using more of the knotless anchors, so that's made me slightly more likely to use more anchors. So I have a very soft threshold that if it's less than 20 millimeters, I'm probably going to try to do a 2 anchor repair. If it's one of those, I'm talking about the distance between the medial anchors, anterior to posterior distance on the glenoid anchors. If it's 25 millimeters or more, I'm probably going to be using 3 medial anchors, because I am concerned about the glenoid fixation, although the studies have shown lateral failures also, and I've seen that. Mike, how many anchors do you use on the glenoid?
I use 3, but I started with 2, and I thought that, I don't know, I thought the fixation was better, and I just used 3, 1 at the 12 o'clock position, and then like 11 and 1, or just beyond that on each side, double loaded suture type of anchors. And that's just what I have done.
I think if the space is a little less as you're kind of learning this operation, if you're initially only have to do 2, it's nice. But if it's a big space, I think I like 3 anchors. It snugs it down nicely. So a lot of the procedures have used in the double row with the lateral row. To me, intuitively, it wraps over the top. Maybe it's less likely to catch on the acromion. I don't know that it's always necessary. There are papers on single row for the lateral fixation of the graft, but I've not yet tried that. Have either of you attempted it?
No, not a single row for SCR. I haven't tried.
Me neither.
All right. I think I asked these questions before. There was one more comment about the bicep. On occasion now, if the bicep's not diseased, I sometimes leave the bicep. In this article from JSES, about a third of the time they tenodece it, a third of the time they cut it, and almost a third of the time they just left it, and some of them already had a bicep tenodesis, so it wasn't quite a full third. But I also saw him at Hoenecke, and I saw him leave the bicep. He didn't take it. So I'm not sure it's necessary always to take the bicep or to tenodesis, although maybe it's an aid, as you demonstrated, in adding collagen anyway. But I have left it on occasion. So.
Well, thanks, Heinz. That's
Yep.